Okay, let's learn about shock liver. Shock liver is basically also known as ischemic hepatitis. Okay, ischemic hepatitis or hypoxic hepatopathy. Why it is called so? Because it is caused by ischemia to the liver cell or hypoxia to the liver cell. And going towards the pathophysiology. Okay, pathophysiology. Our liver is basically supplied by portal vein, portal vein, and hepatic artery. Okay, and portal vein supplies 75% of our liver low oxygenated blood. Okay, while hepatic artery supplies about 25% and is highly oxygenated. And during shock, what happens? Our this hepatocytes, okay, hexagonal hepatocyte in this corner, there are three things. Okay, our portal vein, hepatic artery, and biliary duct. Okay, and in the middle there will be uh, central vein. Okay, and blood flows from here to here. Okay, there is zone 1, zone 2, and zone 3. In the middle there is zone 3. Zone 3 is always gets low oxygen, while zone 1 gets more oxygen. And during shock, what happens? During shock, whenever there is low perfusion, okay, to the body, and then this zone 3 get ischemia first. Okay, okay, and whenever there is reperfusion, reperfusion, the reperfusion injury also occurs, and due to which there is massive, okay, after hepatocellular necrosis during shock from zone 3, there is massive rise of transaminase. Okay, transaminase towards our blood. So the shock liver is a condition uh, in ischemia or shock where the ischemia of the zone 3 occurs, and after reperfusion there is massive rise of transaminases in our blood. So the causes, what are the causes of shock liver? Shock liver is basically caused by any type of shock. Okay, a cardiogenic shock or septic shock or hypovolemic shock, any shock can cause it. Okay, and or hypoxia can also cause. Okay, hypoxia can also cause hypercapnia, increased CO2 also can cause. And whenever there is massive p, it also can cause this ischemic hepatopathy or shock liver. Okay, what will be the clinical feature? The clinical features usually occurs after hours to day of shock. Okay, at the time when the patient presents with the shock liver, features of shock liver, the shock may not be there. Okay, and sometimes there can be mild right upper quadrant tenderness. Okay, and jaundice can be mild, less than 5, and there can be signs of shock sometimes, or that may not be there as well. Okay, well, lab finding helps us to know it's a shock liver. The AST and ALT will be massively raised, often more than 1000. Okay, IU per liter, and usually AST is more than ALT. Okay, and it normally peaks around 1 to 3 days and normalizes in 7 to 10 days. Okay, if perfusion is this recovers. Okay, LDH is very high. LDH is very high, often higher than this AST-ALT. Okay, often higher than AST or ALT. Okay, and this LDS basically helps us distinguish ischemic hepatopathy. Okay, bilirubin, as I already told you, bilirubin is mildly elevated, mostly less than 5 milligram per deciliter, and ALP or GGT is normal or slightly increased only. INR sometimes can increase but may not increase. Okay, and basically it's normal. Okay, creatinine and this can increase because of shock only. Okay, shock in due to shock. Okay, and how do you diagnose? Diagnosis is mostly based on the clinical feature, the biochemical, this everything just I told you, and the context. Okay, context of shock. Okay, and and for this we have to exclude other causes like viral hepatitis. In viral hepatitis also there is increase in ST more than 1000. Okay, and due to toxins like PCM poisoning, any biliary obstruction or something like that. But these are all obvious in from history and our imaging finding as well as the lab finding as well. And what about imaging in imaging? Okay, USC with Doppler. If you do that, then it might show congestive liver. Okay, congestive hepatomegaly, or hepatomegaly can be seen, or poor hepatic vein flow in the right hepatic failure. Okay, and congestive hepatopathy or poor hepatic vein flow. Okay, and basically imaging helps us to distinguish between other causes, to differentiate or rule out this ischemic hepatopathy from other causes like biliary obstruction or hepatic vein of thrombosis. Okay, management is basically management of the shock. Okay, there is no specific therapy. If you correct shock, then it will get corrected, and management treatment of shock and avoid any hepato this hepatotoxic drug. Okay, hepatotoxic drug. Okay, thank you.